Good morning, all. Today's topic for discussion is color changes of teeth. Coming to objectives, here the student should be able to understand the different types of staining of teeth. There can be extrinsic stains, there can be intrinsic stains, and also the treatment or management of staining of teeth. Coming to extrinsic stains, the most common are bacterial stains, iron staining due to tobacco, due to food and beverages, gingival hemorrhage, respiratory material, as well as medication. And intrinsic stains you have due to many developmental disorders like amelogenesis imperfecta, dentinogenesis imperfecta, dental fluorosis, erythropoietic porphyria, hyperbilirubinemia, pucronosis, trauma, localized red blood cell breakdown, as well as medications. Coming to extrinsic stains, among bacterial stains, we know the chromogenic bacteria is responsible for causing green, black, brown to orange color staining in the teeth. In the children, you can see in the labial surface of maxillary anteriors, mostly in the gingival 1/3, it can causes different kinds of staining. It is mainly due to this chromogenic bacteria. It may be this chromogenic bacteria can be present in saliva or the pericula fluid. Coming to tobacco, tea, or coffee, it causes brownish discoloration. It is most commonly seen in the lingual surface of mandibular incisors. And tobacco, it can even stain the pit and fissures in the teeth. And even food containing chlorophyll can cause a slight greenish pigmentations in the teeth. Gingival hemorrhage can result in green stains in the teeth. It is due to the hemoglobin being broken down to biliverdin, which is green in color. Even some certain respiratory materials like amalgam can cause a black-gray discoloration. So here coming to the picture, we can clearly see amalgam restoration can cause a dark brownish discoloration of the whole teeth meal. And in the second picture, you can appreciate that it can be both due to a tobacco staining as well as a frequent tea users. And the third picture just shows it is artificial coloring of teeth. Coming to medications, we know iron containing as well as iodine containing medications can result in blackish stains of the teeth, as well as medications containing sulfides, silver nitrate, manganese can result in gray, yellow, brown, or blackish type of discoloration. Medications containing as copper and nickel can result in a slight greenish staining. Cadmium can result in yellow to golden brown stain. The stannous fluoride, which we are mostly using as mouthwash, it can even result in black stains. Fluorescent mouthwash on frequent use can result in yellowish brown staining of the teeth, which is mostly seen in the interproximal surface of teeth near the gingival margin. So this diagram is a typical example of tobacco-related stains, as well as the second diagram is mainly, we can see it is seen in the interproximal surfaces due to the frequent use of chlorhexidine in mouthwash. Coming to intrinsic staining, the most important one is the congenital erythropoietic porphyria. It is an autosomal recessive disorder, a disorder of porphyrin metabolism, which can result in a generalized reddish brown staining of the teeth. Here, it causes red fluorescence under UV light. Here, it can be also seen in the deciduous state and involving both enamel as well as dentin. Book chronosis, here it is an autosomal recessive disorder. It causes a blue-black discoloration in the connective tissue, tendons, as well as cartilages. Patients with Parkinsonism, the treatment or the medication they are using can cause a bluish discoloration in teeth. Hyperbilirubinemia. The dental changes can correlate to the period of hyperbilirubinemia. Mostly it affects the primary dentition and the cusp of permanent first molar occasionally. And here it results in the green discoloration of teeth. Again, the causative agent is the same, that is bilirubin being taken down to biliverdin, which is green in color. Now, what are the causes of hyperbilirubinemia? The major or important thing is erythroblastosis fetalis or biliary atresia. Also, there can be reasons like premature birth, ABO incompatibility, neonatal respiratory distress, significant internal hemorrhages, congenital hypothyroidism, biliary hypoplasia, metabolic diseases, as well as neonatal hepatitis. Now coming to erythroblastis fetalis, we can see that hemolytic anemia of the newborn or RH incompatibility between mother as well as fetus is responsible for this condition. Biliary atresia means here you have a sclerosing process of the biliary tree. So in the first diagram, you can clearly appreciate that starting from the cervical 1/3 to approximately to the middle 1/3, you have a slight grayish discoloration or a slight greenish discoloration in hyperbilirubinemia. In erythropoietic porphyria, you can see there are generalized reddish brown stains which can be present in both the deciduous as well as the permanent dentition. Due to trauma, we can see it can progress from a pink color initially, later yellow, and later dark gray. The dark gray discoloration indicates the pulpal damage that has occurred in the teeth. A late yellow discoloration may give an inference of pulpal obliteration due to localized RBC breakdown. So here, the pink discoloration is due to the hemoglobin broken down within the necrotic pulp, and it is seen mainly in the crown portion of the teeth. In leprous leprosy, you can also see that there is a pink or a slight red discoloration of the teeth, mostly in the maxillary incisors. That is due to the infection related to necrosis, which causes rupture of the pulpal blood vessels and the hemoglobin being released into the dentinal tubules. So in the first figure, you can see in trauma, here you have a generalized yellowish discoloration of the maxillary incisor teeth. And the second diagram, it is in more initial stage of trauma where you have a generalized pink discoloration of the teeth. Coming to tetracycline staining, here we know it depends upon the time of administration, dose, as well as duration of medication. In case it causes varies from bright yellow to dark brown in color. The bright yellow fluorescence is seen under UV light. Chlorotetracycline can result in a gray-brown discoloration, whereas oxytetracycline can result in an yellow discoloration. Minocycline. Here, the stains are fully seen in the fully developed teeth in the incisal third threefold. And it tends to bind to the collagenous tissue, that is the pulp, dentin, bone, as well as dermis, and later resulting in oxidation and causing discoloration of the teeth. In the initial diagram or the first diagram, you can see that it is a typical feature of tetracycline medication. You can see a pattern of discoloration seen in the whole teeth. The fluorosis, we know that there are different grades of fluorosis, which starts with the initial white spots in the teeth, which can later progress to brown spots and even tipping or breakdown of the incisal edges. Okay. Now, finally coming to how can we manage this for this the management of this extrinsic stains as well as intrinsic stains. For extrinsic stains, maybe a polishing or is the first initially a scaling should be done. Later, we have to give polishing also with fine pumice. We can also suggest polishing along with pumice and 3% hydrogen peroxide, as well as polishing with a bicarbonate spray solution. And whereas for the treatment of intrinsic stains, we can go for a full ground preparation of the teeth. You can do bleaching, which can be even done with lasers, and we can also suggest for a composite veneering. So that's all today. Thank you.